Christian Medical College, Vellore. He is not only an exemplary academician, he is also an astute clinician who has worked in liver units of hospital both in UK and Australia and has several acclaimed publications to his name. He has published extensively on viral hepatitis, liver disorders in pregnancy, and chronic liver disease. He has several honors and awards to his credit, including the Indian Society of Gastroenterology Young Clinician Award in 2001 and the Sheila Sherlock Fellowship Award by the European Association for Study of Liver in the year 2004. He has also served as the medical superintendent of Christian Medical College, Vellore between 2012 and 2017. Sir, I welcome you to the stage to talk on your presentation on hepatorenal syndrome. Before I hand over the stage to you, I would like the audience to know you can ask your questions through the QR code which is printed on the back of your conference booklet. You can post your questions there. The questions will be discussed at the end of the talk based on the time permits.
Thank you. I'd like to thank Vinoy and the organizers for inviting me to be the opening batsman today, and it's very nice to meet up with Dr. Chako and Dr. Tamilarasu again after many years. Good morning, ma'am. I was asking who the audience would be. I'm told that mainly would be students, but some will be faculty as well. So it's sort of, what I hope to cover is, I hope something which will interest both sections. And the first section is more on an exam mode, or more for the student mode. The second section is more to make you think as to how in your own practice you may want to take things forward. So the interaction between the liver and kidney in cirrhosis patients, the term hepatorenal syndrome is used, but you often find that the liver and kidney may become dysfunctional or fail in different other scenarios where it's not necessarily the term hepatorenal syndrome. So I'll start with hepatorenal syndrome. This refers to in patients with cirrhosis, and you're all very familiar with it. There is a marked reduction in GFR, and a kidney biopsy does not show any substantial changes on the kidney biopsy. It's a functional disorder of the kidney, and it's with a high mortality rate. What is potentially reversible with pharmacological therapy or with liver transplantation. So if a liver transplant is done, the kidney function returns, reverses, suggesting that it is a functional problem linked to the liver failure. As you know, all definitions and categories keep getting revised. So the latest revision of the two forms of HRS is now divided into HRS-AKI and HRS-CKD. So when there is an acute decompensation in a patient with cirrhosis and HRS happening, that is HRS-AKI, while the GFR being less than 60 for more than 3 months in a patient with cirrhosis is termed HRS-CKD. So this is the current nomenclature on this. When I was reading up last night for this talk, I was very happy to see that Chinmay Bera, who is our first DM hepatology student, has now been working with Florence Wong, who's an international figure in HRS circles, at least in hepatology, who's in Toronto, Canada. So the definition of AKI is, in setting of cirrhosis, is an increase in creatinine of more than 0.3 or greater in 48 hours, or an increase by 50% above the baseline. And if the increase, depending on the fold increase, it can be divided into stage 1, 2, or 3. And if the serum creatinine is more than 4 at baseline, or if there is already renal replacement therapy, that is stage 3 AKI. And the diagnostic criteria for HRS, again, is something which you're all very familiar with, in a patient with cirrhosis and ascites, with stage 2 or more AKI, and no response or only a partial response after 2 days of withdrawing diuretics and volume expansion with albumin, no shock, no concomitant nephrotoxic drugs, and nothing to suggest an intrinsic renal disease or an obstructive renal pathology. So this is the classical criteria for diagnosing HRS AKI. The pathophysiology is not well understood, but is all seem to be linked to the theory is that the splanchnic system is vasodilated. The splanchnic arterial vasodilatation seems to be the key, and that leads on to a redistribution of the arterial blood volume. So there is a reduction in the effective arterial blood volume. There is a activation of different vasoactive systems, and you're all very familiar with it, with the renin-angiotensin-aldosterone system, the sympathetic nerve system, and the ADH or the arginine vasopressin system. So these get activated. This leads on to constriction of the renal, the afferent glomerular arteriole, and leads to a reduction in the kidney blood flow. So this seems to be the pathophysiology, is our current understanding, and the drugs used are thought to sort of squeeze the splanchnic circulation and cause vasoconstriction of the splanchnic arterial system to reverse this mechanism. So how do we then approach a patient with AKI in a patient with cirrhosis and AKI? So one is to try and decide, is it a pre-renal problem or a structural renal disease, and then to see what is the stage of the disease of AKI. Look for precipitating factors and withdraw diuretics, volume expansion of the albumin, and if there is no volume response, does it fulfill the criteria for HRS? Then consider vasoactive drugs and albumin. So in this flow, it takes 48 hours before deciding to go on to the use of vasoactive drugs like terlipressin. That's how the system, as this algorithm works. And in a person who is a candidate for liver transplantation, then one tries to make transplant happen. But in a large number of patients, that's not possible, and this being a high mortality condition, many patients may die. So the first choice treatment now to treat HRS AKI is this combination of terlipressin plus albumin. And as you know, terlipressin is a vasopressin V1 receptor agonist. So it causes constriction of the splanchnic arterial constriction, counteracting the splanchnic arterial vasodilatation. And this leads to a reduction in the portal pressure, increase in MAP, and increased kidney perfusion. The albumin is given concomitantly, got both oncotic and non-oncotic properties, and improves the effective arterial blood volume, increased cardiac contractility, and stroke volume. The next commonly used drug is noradrenaline or norepinephrine. So what are the key differences? For noradrenaline, one needs a central line, while terlipressin can be given either via peripheral line or via central line. For this reason, the person on noradrenaline is always in the ICU, while with terlipressin, one can either use it in the ward or in the ICU. Now, costs are much more with terlipressin compared to noradrenaline. What was eagerly awaited now was the US FDA approval for the use of terlipressin for HRS. The whole world has been using terlipressin for HRS, Europe, India, Asia, etc. But US was not using. And finally, now the US FDA approval has happened, I think it's this year, and I'll show a bit about that. So for the US FDA approval, this was the study which made the difference. It's called the CONFIRM trial. And as I mentioned, Florence Wong is the first author in this, came out in 2021. So this is the world's largest number of patients recruited in this randomized controlled trial of using terlipressin plus albumin versus placebo to treat type 1 HRS. So they had a total of 300 study patients randomized to the two groups. They had a 2:1 terlipressin to placebo, and both groups were given albumin as per the clinician's choice. The primary endpoint was reversal of HRS. So prior to the study, the US FDA took the stance that efficacy may be, but safety was a concern. So mainly on safety grounds, USA was not allowing the use of terlipressin in that country. So the findings of the study showed that the primary endpoint of a verified reversal of hepatorenal syndrome happened in 32% of patients who got terlipressin compared to 17% with placebo. And that is a significant finding, statistically significant as well. So it clearly improved HRS in 30% of people, there was reversal. However, the liver transplant-free survival was no different between the patients who got terlipressin or placebo. One new finding was that 11% of patients had deaths due to respiratory failure. So this has not been recognized earlier as a side effect of terlipressin, and that's a finding which has come out of this study. So as the US FDA has approved this drug now, terlipressin plus albumin combination, there's a focus also on trying to prevent deaths from respiratory failure, which could be a complication of the use of terlipressin in this scenario. So this confirmed study concluded that in adults with cirrhosis and type 1 HRS, terlipressin was more effective than placebo in improving renal function, but had higher serious adverse events including respiratory failure. Now let's look at the cost. For anything, the cost is different between India and USA. So in India, 1 mg of terlipressin may cost 2,000 rupees. FDA is approved now, so in USA is available. It's 1 mg is $1,000, which I think is 85,000 rupees. So if you use 8 mg per day, so it's like 40 times. And if you use it for 7 days, in India it'll cost 1 lakh. In USA, this is now 48 lakhs. But now this important study has been approved, has been accepted, and US FDA has approved. So now, so this is one of the fallouts of this US FDA approval. What happens if the kidney function doesn't resolve? Only in 30% of patients did the kidney function resolve. Now, to have the option of doing a liver plus kidney transplantation is quite a challenging task to do in any transplant center, I would guess. So the recommendation by the American guidelines is that in this scenario, if there is more than 6 weeks on dialysis while waiting for liver transplantation, is the indication for liver plus kidney transplantation. So in HRS patients who are not responding, the renal function not responding, and 6 weeks are over on dialysis, the recommendation now is, while the European guideline says 8 to 12 weeks. So that is the only difference. The time duration is slightly different. Which means that one is hoping that can we have the kidney function to recover, which we know recovers, is a functional problem only, and have survival with the native kidney rather than having a kidney transplant, okay, in this scenario. So let me move to the second part of what I would like to cover. I'm moving away from HRS, but there's still a link between liver and kidney. So in different situations of acute injury to the body, which provokes an inflammatory response, one may encounter dysfunction or failure of the liver and kidney and other vital organs. So can any treatment improve survival with the native organs without having, say, liver transplantation or kidney transplantation, etc.? So in that, I would like to now delve the next few minutes on the topic of plasma exchange. Now this systematic review, this meta-analysis was done by Dr. Kaushala, who had come from Sri Lanka and spent 1 year with us and got published last year, where the published literature now suggests that in patients with acute liver failure, plasma exchange improves survival, especially when we take the studies with a single etiology of acute liver failure. Now, this is work from within CMC, where patients with severe alcoholic hepatitis who also meet the criteria for ACLF, that is acute on chronic liver failure, when compared to standard medical therapy, had not a very impressive, when you look at it, it doesn't look very impressive, some improvement in survival over 1 year, but it is significant, statistically different. There was seem to be some difference. So the signal seems to be going the correct way. Now, in that particular paper, of the 21 patients who underwent PLEX, so they all had severe alcoholic hepatitis, 10 also had raised creatinine. And 6 out of 10 who were all treated with PLEX, the creatinine improved, while in 4 it did not improve, and those it remained high, all died. None survived. Now, further, as more patients got added on and further analysis by Santosh in our department now shows that the survival curve starts to separate out when we compare the use of centrifugal plasma exchange and membrane plasma exchange. So, it is evident that in this disease, in severe alcoholic hepatitis bar alcohol-related ACLF, as compared to standard molecular therapy or with membrane plasma exchange, with centrifugal plasma exchange, 1 year survival is significantly better. Now, as of now, 1 year survival improvement happens in the disease only with liver transplantation. The short-term improvement of 28-day improvement survival has been reported with the use of steroids in the Western world, but there is no other treatment has been shown to improve this 1 year survival. So, if this is true, why does it happen? So, we have looked at the different technical details of the plasma exchange, and we believe the important thing is about the flow rate. With the centrifugal process, the flow rates are very low, flow rates are achievable compared to the membrane. And we think that has an impact on why this improves, is our hypothesis. Similarly, when we looked at our own published data on rat poison, rodenticide, phosphorus-induced liver failure, again, we have shown that this is now improving survival compared to historical controls. A proportion had raised creatinine as well, and with plasma exchange, it improved. Now, it's quite possible that such a person will improve without plasma exchange, the creatinine, the renal function. So, it's a bit like giving 2 liters of oxygen. It's like an adjunct of therapy only. But I hypothesis, if we treat more such patients, more number of patients, would the number improve be greater than those given only medical therapy? So the Tamil Nadu chapter of the Indian Society of Gastroenterology now recommends the use of plasma exchange to treat rodenticide poisoning. However, I just want to highlight here that they have recommended the use early in the disease, even without encephalopathy, when they are only having coagulopathy. So let us take the conception of a poison which causes a liver failure. Such examples can be paracetamol overdose, and for India it's rodenticide poisoning. Now the current guideline is to treat, the European Association EASL guidelines is to treat acute liver failure with paracetamol overdose with urgent liver transplantation, CVVH to reduce the raised ammonia levels, and if there is no transplant option, then consider plasma exchange. While the Tamil Nadu guidelines which are referred to, which now has been adopted by the government of Tamil Nadu, advocates the use of PLEX even earlier in the illness. I'm just stating this because I believe that this will apply to different scenarios encountered in nephrology where acute inflammation drives organ failures. I mean, such patients are primarily under medicine or pediatrics, but all of our specialties are getting called in. So I'm just showing this for you to think about as to would you like to apply that and think in your own scenarios. So we've moved earlier in the illness and doing plasma exchange. Now Vijay Alexander, again in our faculty in our department, has shown that patients who are not on a ventilator with and had this severe liver problems are unlikely to get transfusion-related lung complications. So this is a nice window for a patient selection. TALI, TACO, the TALI was nil and TACO was very low. These are highly serious conditions and potentially fatal complications to get. So to select a patient is a person who's not ventilated, who's got acute liver failure, acute liver injury. I'm talking liver, but I'm asking you to think about kidney. Now it's possible, it's known that patients with acute liver failure have vasodilatory shock. Now, this is also similar to what is seen in sepsis. Now, if we then remove blood from such a patient, we may be turning things in the wrong direction. So this is work now by Dr. Ashisha, again faculty in our department, where she's collated data from different centers in India on the use of plasma exchange to treat hepatitis A and acute liver failure. So these were all patients who were unconscious or encephalopathic. Now, when compared to standard medical therapy, in the whole group, there was no difference in survival. But when we take the patients who are not on inotropes, the survival is better with plasma exchange. So it appears that, again, a person who's not on inotropes is again a good stage, good situation to consider doing plasma exchange. So we have now been increasingly doing plasma exchange in our department, and we do for liver transplants predominantly or almost exclusively cadaveric liver transplants here, and the numbers are given at the bottom row. So it's almost maximum 1 a month. Most of the patients who are undergoing plasma exchange would warrant an urgent liver transplantation and are not having that option coming out, urgent transplantation. So in such a situation, we are increasingly doing plasma exchange because we seem to sense a survival benefit. Now, as you can see, of the 62 patients, majority were not in the ICU. So we're catching them early in the illness, and that's where we're doing this treatment. Now, this seems to appeal to the government. To do transplant is a bigger task than doing treatments like plasma exchange, especially with liver transplants. And so thereby, Tamil Nadu government has endorsed Plex to treat rodenticide poisoning, and in different districts in Tamil Nadu, in 18 districts, in the district government medical college hospital, plasma exchange facilities are now provided for rodenticide poisoning, and Kerala government has endorsed this for severe hepatitis A. In the 2 years, 2022 to 23, in the government sector, 1,237 patients in Tamil Nadu underwent Plex to treat rodenticide poisoning, while only 3 patients could undergo urgent liver transplant during this time. So that means it is scalable and it's happening at this. So here's the proposal. I am saying liver, you should think kidney. Is there an indication for renal replacement therapy? And there are classical indications, you will know it better than me. If there are no indications, but they still have dysfunction of liver or kidney in an acute inflammation, consider plasma exchange. If there is indication for renal replacement therapy, then I would push to say, consider using CVVH or SLED, which have lower flow rates compared to intermittent hemodialysis, and the use of plasma exchange. So this is my last slide. Now, everything keeps changing. They say the half-life of knowledge is very short. I read somewhere it's 21 days. So it's like saying if you have an exam question set, by the time the exam delayed a little bit, the question paper may become outdated. Treatments also keep changing, and ideas keep changing. So there are a few case reports. These two I picked up from, one is from AIIMS Rishikesh, other one is from Manipal, where they use Plex to treat viper bite-induced TMA and acute kidney injury. I know that there is a systematic review showing that it doesn't work, but I am not so sure. However, it's not my field, but I'm just raising provocative questions for you to think about, that selection of the patient, and I gave examples of how earlier in the illness and non-ventilated patients and those who are not on vasoactive drugs, etc., seem to make sense for us to do. So lastly, why does this occur? Why is there an improvement in survival? So we believe it's something to do with traffic jam. So everyone has experienced traffic jam, yeah? So this is the picture on the left is the old hospital in CMC in Vellore campus, where it's 9 o'clock in the morning. The road in front is called Gandhi Road. The road is jammed. There are bullock cars, auto rickshaws. So if somebody had a myocardial infarction, that person may die before reaching the hospital. You can see the liver there, the grey colored building. That's starting to fail now. But by 3 in the afternoon, the traffic is flowing very well. The liver is functioning again, or the kidney is functioning again. So it's possible that the perfusion in the microcirculation is getting jammed, and then jam refers to reversibility, reversible, and maybe that's what's happening. the same concept we try to put into a more scientific format in this cartoon. Thank you.
Audience questions that I would like to ask you, please. The first question being, how would we choose between norepinephrine and terlipressin? Is there any role for a combination of the two?
Okay. The preferred drug is terlipressin. The data is now more and more strong. So one would use terlipressin if that option is available. However, it's cheaper to use noradrenaline. So if terlipressin is not an option for cost reason, noradrenaline can be used. But patients with noradrenaline have to be in ICU, which means the cost will again go up in that way, while the terlipressin patient can be in the ward. So both options are possible, but the data is mostly there with terlipressin. The best data is with terlipressin.
Thank you, sir. So the next question, in patients with HRS on dialysis for 6 or 8 weeks, is there any role of renal biopsy to decide whether the kidney needs to be transplanted, or do we go by that timeline that has been decided?
I wouldn't be competent to answer that. I'll maybe get the House's opinion on that. But I'm not sure. It's not the kidney biopsy which makes the decision. It's a recovery of renal function is what I know. They've used urinary NGAL as a cutoff level to say, can it predict those who would improve the renal function or not, etc. have been used.
Thank you, sir.
Thank you very much, sir, for this excellent presentation, which has definitely broadened our insight into hepatorenal syndrome. We request you to kindly accept a small token of appreciation from our department.